I am Liz Powell. I am the founder and head of G2G Consulting, and I get the wonderful role of kicking things off today. We are talking about women's health, the elections, policy, advocacy, and what next. We have an amazing panel of speakers with amazing expertise, background, in all kinds of women's health issues and in advocacy and ways to influence the process. So I'm really excited for today's discussion. I'm going to start things off with an assessment of the election. So I think at this point, we all know Trump won. And the voting turnout was a little bit lower than 2020, but still pretty solid. The electoral vote is what determined the winner, which obviously was 312 to 226, Trump to Harris. Interestingly, he also won the popular vote. And so this time we really do consider it a red wave because he was also joined by the House and the Senate. What's interesting is that we're seeing a shrinking gender gap. It was not nearly what people thought it was going to be. And what's really interesting, white women as a plurality have only voted 2 times for a Democratic presidential candidate, and that was in 1964 and 1996. So that is a key block. Another key block, Latino men backed Trump by 10 points, but they backed Clinton in 2016 by 31 points, and then Biden by 23 points last time. The Black support was up 10% for Trump, but 85% of Black women supported Harris, so that's a solid block. The rural vote also is really interesting, 59 to 39% in small towns and 66 to 33% in rural areas for Trump as compared to Harris. The Senate flipped to Republican control, and by a comfortable margin. It is not filibuster proof. However, they can do a lot of things with this power. The pickups were Ohio and Montana. Those were Democratic seats that were lost to Republicans. Pennsylvania, McCormick has been declared the winner, but Casey is still challenging that. West Virginia was a clear landslide, so that flipped from Manchin, who caucused with the Democrats, to a Republican, the former governor Justice. Arizona, Wisconsin, and Michigan are all Senate seats that Democrats retained. It's really fascinating how the vote was split. So there were tons of ticket splitters. That's like the big story of this election. A lot of people went out and voted for Trump for president, but then they voted for the Democratic senator or Democratic representative. The House is going to stay in Republican control. It looks like there's still a few seats that they're counting. And there's a big rural shift that's happening among our districts, which I think is also going to be shaping legislation. And then, as I mentioned, where Harris and Biden won in districts and states, Republicans won. And so we're seeing this interesting split ticket. And the other thing is the ballot initiative. So several states had ballot initiatives, Arizona, Colorado, Maryland, Missouri, Montana, Nevada, New York. So now there's 11 state constitutional amendments. Several already had them, but 3 failed. And in Florida, it actually required 60%. So that was a much higher standard than the other states. There were other interesting ballot initiatives on banning non-citizen voting, minimum wage increases, even ending a diaper tax. So other factors, like in Arizona, there are over a dozen ballot initiatives. So there's a lot of things that were shaping voters. And so because things were sort of split up, voters could vote for abortion rights and then vote for Trump. And sort of it was either way for the representative down ballot. Some voted R, some voted D. So I think that ticket splitting is what's really interesting factor in this election. Currently, the House is at 220 Republicans to 211 Democrats. So the Republicans will have even more folks, more seats for them to move through their legislation. And I'm going to get into what does that mean? What's next for the new Congress and the new administration? But now I'd love to pass it to Beth Garner, who is going to lead our discussion with our amazing panelists today.
Thank you, Liz. Wonderful. Thanks for that overview, Liz. Very helpful. So I'm Beth Garner. I'm a women's health physician by training. I am the immediate past president of the American Medical Women's Association, and I also do quite a bit of consulting in the women's health space. So I'm really excited for this discussion today. So with these great summaries and insights that Liz has just provided us, we're now going to have a discussion with our panelists to talk about what we might and can expect, right, as it relates to women's health going forward. And many of you on this call may be aware of all of the exciting stuff that's been happening in this space over the past few years. There's been increasing interest, innovation, and investment in women's health. And all of us here today have been a big part of that. And we decided with Liz that, given the outcome, either way that it had gone, the plan was to have a discussion about the path forward. So I'm going to introduce now our wonderful panelists. Today we have Linda Goler Blount, President and CEO of the Black Women's Health Imperative. We have Netta Hanafi, founder and manager of MedTech Strategy Advisors LLC and co-founder of MedTech Color. Dr. Mitzi Krockover, founder and CEO of Woman Centered LLC and host and producer of the Beyond the Paper Gown. And did Elena finally join?
Mm-hmm.
Great, fantastic. Elena, I couldn't tell there you are, wonderful. President of the National Hispanic Health Foundation. So super exciting. So if you could all, if you're not already on, yes, you are. Fabulous. All right, so I have some questions that I've put together, but as I just said to our panelists, we're going to really see this as a discussion, right? So I'm going to be asking some questions, but I've encouraged our panelists to, just sort of jump in where it's where they think there's something to add to what the other panelists have said. And then we will have some Q&A at the end. So please, as you're listening through the conversation, please be thinking about what you'd like to ask about, but also what you might be wanting to also say. So let's start with Mitzi. First question. So in thinking about, and all of this, obviously, I didn't say, right, is all about, how are we going forward as it relates to women's health? So pretty much most of the questions will be around that. So Mitzi, what do you see as the most pressing gaps currently in women's health? Things that require immediate legislative action, and then how can we, individuals, participate there? But also, how are you thinking about potential, say, public-private partnerships that can address those gaps?
Sure. And if I can just add, one of my other hats that I wear is as the managing director of Golden Seeds, so an angel investment organization that focuses on women-led companies. So I also have that perspective as well. I want to thank Liz and G2G Consulting for inviting me and for having this great conversation, along with all my colleagues here who are terrific. I think the number one, number two, and number three is the maternal health crisis. We, as a nation, are number 24th in maternal mortality. That means that there are 23 other countries in this world that have better outcomes than we do in terms of women dying in pregnancy or afterwards. And for Black women, it's 3 times worse. And so we really need to get a handle on this because it's not getting better, it's getting worse. And so I think, and then we have some other things that have contributed to the problem, and that is that GYNs are leaving, or OBs are leaving the practice. And so we have OB deserts. A third to a half of our counties don't have any kind of opportunities there. And it's a lost leader for hospitals. And so as they get bigger, they are actually reducing their OB services. And so I think that we need to address those issues, both from a maternal health and how we can support women. One of the, I think, great things that has happened is the Black Momnibus Act, which has a number of areas that has addressed this issue, including expanding Medicaid for 12 months after pregnancy, which I believe before it was 6 months. And that way we can attend to high blood pressure, diabetes, postpartum depression, and support of the mom. So I think that is one example of how that has really helped. And we know that those states that adopted those first had better outcomes than the states that lagged behind. And now those states are starting to adopt it. So that's, one area. In terms of the public-private partnership, we're seeing so many great companies right now, everything from remote monitoring of high-risk OB to screening for postpartum and peripartum depression, just again, supporting women through that whole journey. And so to the extent that the government can support the research and funding that goes to, create those, to be able to provide incentives for those companies to be able to do what they're doing, to training the medical community about how to, take care of women better. All of those can be policy related, but they're also, again, really require the private sector to really step up. And so, and then the insurers, that's the other piece. If we don't have reimbursement for some of these services, then they usually are not accessible. The other piece I will say is telehealth. There is a question about what's going to happen with telehealth reimbursement for physicians. And so if that goes away, then women are going to have less access, especially in those OB deserts, to healthcare. And so I hope that anybody listening that is, has anything to do with this will, help to think this through, because it's really an important piece of women's health. So I know that was a long answer, so I'll just tell you a couple of others that I, again, won't go into such detail. Reproductive health access, we know that, and that includes sex education, contraceptive choice, as well as violence against women, because that is unfortunately a reality for a lot of women, and it does impact on their reproductive health. And finally, chronic disease management, a real focus on going from lifespan to health span, and looking at women's health in a much more inclusive way. We know that, again, it's not just reproductive health, but those issues that manifest differently, like cardiovascular disease, or disproportionately like autoimmune diseases, osteoporosis. 80% of people with osteoporosis are women, and 66% of people with Alzheimer's disease. So we've got areas such as, again, research, funding research is really important. We also have medical training acts that are being proposed, such as the HEART Act, to help providers know exactly, how to treat women, because our outcomes are much worse than men, as well as obesity management education, reimbursement for menopause services, reimbursement for bone mineral density studies, and also for secondary screening for women who have dense breasts, for example. So I'll stop there, but you can see that there's a lot of opportunities for policy and the private sector and the public sector to come together. And a lot of these acts, by the way, were actually advocated for by some nonprofit organizations, including the Menopause Foundation, Black Women's Health Imperative, as well as Women Heart and the Brown Foundation. So again, I'll stop there really right now and just say I think that there's really a role for everybody.
That's great. Thank you. So moving on and sort of continuing on in some of your comments already, I want to turn to Linda now. First of all, I have two questions for you. One, can you give us any more comment on the maternity health crisis? And specifically as it relates to Black women, you heard the numbers, right? And despite the fact that I talk about this and hear this all the time, I'm always shocked. And I grew up actually in a third world country or a developing country, and we basically are starting to look like that here. So, but if you could talk about that, and then to also to what Mitzi was starting to talk about around advocacy, right? What strategies will be useful for effective advocacy around all of these health disparities?
Yeah, thank you, Beth. And I also want to offer my thanks to Liz and G2G Consulting. And it's, it's great to be here with this particular group to have this conversation, but also at this time. There's probably not a more important conversation than we could have. Just to put a finer point on Mitzi's observation, when we look at health disparities in maternal health, Black women have a 3x higher rate of maternal deaths at the national level. But in places like Washington, D.C., or in Alabama and Georgia, it could be as much as 9x or 12x. We're 10 times more likely to die. And just to sort of frame it, because we tend to look at these issues in terms of poverty, but Black women who are college educated, high income, high professionals have a maternal mortality rate worse than white women without an 8th grade education. So it is not a poverty issue, it is a treatment issue. So, and when you are pregnant and go into labor and you go to deliver your child, you want to know that you're going to be treated with the standard of care, with respect, that your providers will listen to you if you say something doesn't seem right. But unfortunately, Black women and women of color can't count on that. And so there is no biologic or genetic explanation for these kinds of mortality gaps. This is purely an issue of access and treatment. So
That's such an important message, Linda. So important, because I believe that most people, when they hear these numbers, are like, oh, well, of course, right? So, yeah.
Yeah. And so when we think about advocacy, there's advocacy for these big P issues that Mitzi was talking about, these policy changes. But advocates in this space also have to look at what's happening when it comes to just care delivery, like what's happening in their community. And it's really hard because if you were to survey OB-GYNs, I'm pretty sure none of them would say that they're biased in their care. None of them would say they treat patients any differently, that everybody gets the same treatment, but we know that's not true, because if it were true, we would have the same outcomes. And so with this next administration, we some things we know already. I mean, we know health disparities and health equity and disparities were not popular, and they're not going to be popular. I literally just had a call where people were talking about how language on websites, the CDC website and NIH websites, will be scrubbed, and we will see references to health disparities and health equity removed. But the positive note is perhaps in research, maybe there won't be a huge impact. I mean, people probably will have to change how they write their grants, but the people actually reviewing the research understand the importance of these issues. So perhaps we won't see a huge impact, but that's TBD. But we have to look carefully in a few places. The Affordable Care Act. It's unlikely that the entire ACA will be repealed, but things will be chipped away, we think. Maybe some of the provisions for pre-existing conditions and without copay, some of the screenings that are offered right now without any cost sharing could be removed. At the state level, perhaps we won't see states that have expanded Medicaid go back on that. We don't think that'll happen, but the exchange market may change. I mean, things may move to a market-based approach, which means your access will depend on your ability to pay, which of course is going to disadvantage low-income people. And access points aren't likely to increase in rural areas. Mitzi talked about what happens to people who live in rural areas. Things are not likely to improve for them. And again, just to go back to what Mitzi said, over 40% of all babies in this country are born under Medicaid. So it's great that Medicaid has been expanded, I think in all but maybe 1 or 2 states for 12 months postpartum. But if we change the mechanism by which people have access to Medicaid, then we may well see maternal mortality rates increase, infant mortality rates increase. And of course, with the rollback of access to reproductive health in certain states, we've already seen that. The positive piece, though, is what Liz pointed out, which is there was ticket splitting. So people found a way to vote for a very conservative government while also asking for protection for reproductive freedoms.
Right.
So we'll see how that plays out. I would also point out that in states that have Republican governors, it'll be interesting to see what happens to healthcare, to Medicaid, to spending. I mean, I think, as Medicaid, so for people to know, it is a state-based program. I mean, there is federal funding for it, but there's the saying that if you've seen one Medicaid program, you've seen one Medicaid program. So we could see federal funding decrease, which means coverage benefits and eligibility may change, may become more limited. And that's going to affect, obviously, maternal health, but also chronic disease health, diabetes, heart disease, cancer. And so we could see adverse outcomes in those areas rise over the next few years. I'm also particularly concerned about the breast and cervical cancer early detection program. It already couldn't meet the need. And if we actually roll back some of the funding, that could mean that free breast and cervical cancer screenings, particularly in the southern rural areas, could end. I mean, some of these states were running out of money by May and June anyway. And the sort of the obvious, I think, issue to talk about is what happens with vaccines. I mean, we don't know. We don't know who's going to run HHS, who's going to run CDC. We don't know what the public health response will be, but it could adversely impact access to vaccines. And I think I'll just sort of end with two things. I think it's unlikely that the Office of Minority Health and Health Disparities will disappear. I'm not sure what it will do. I see Elena nodding her head. I'm not sure what their focus will be, but I think from an advocacy perspective, it's important for advocates to understand data and use data and stories together to talk about the impact of these changes in policies on real people, not theoretically, but to actually bring the data and the stories together and talk about any potential harm. Also talk about benefits. Say, look, if we don't do these things, if we keep these policies in place, if we expand these policies, here's the positive benefit and here are the stories to make that case. But there's a lot of that needs to happen over the next 2 years, and especially to connect policies and improved health outcomes for the midterm elections so that when people go back to the polls in 2 years, they have some actionable information to vote on.
Thank you, Linda. That was just amazing. And as always, you've given us so much to think about and so much that we have to do as it relates to advocacy, right? So let's turn to Elena. It's wonderful to have you on this panel. First, can you tell us a little bit about your organization, what your mission is? And then if you could please sort of continue on, because I think you were really, engaged, all of you were, but Elena, I think given that you're in an advocacy role pretty much, if you could continue on and make any other comments to some of the stuff that Linda was telling us.
Yeah, thank you. And thanks for inviting me. I'm glad to be here. I think first of all, the National Hispanic Health Foundation has been around for 30 years. We're the foundation behind the National Hispanic Medical Association and was started as the NHMA Foundation to be the pass-through foundation 501c3 to be able to receive funding from the foundation world and other donors so that we could have the NHMA grow. We started both organizations. I was the president of both up until June 1st. We had our 30th anniversary, and really both boards had been discussing transition planning for the last few years. I thought during the Obama administration I might jump back into government. I was at the Office on Women's Health back in the Clinton administration and very much engaged with the breast cancer advocacy arms at the time. Many of the different women's health groups were very strong, and Violence Against Women Act too. So let me just say that we decided honestly that I would go from the big organization to the smaller organization so I could grow the foundation. And the difference between a medical society that has members and a conference and chapters is that they end up talking to each other.
Yes.
And perhaps to the next generation. We always want to mentor the next generation and educate the next generation, which I have to say is one thing that I want to add to this conversation is the next generation. I know in our generation, we won't see the light of our advocacy, but there has to be hope and change that can happen to improve the quality of our lives if we can build more advocates and more advocacy. That's how I see it. Leaders. But anyway, the umbrella of what we're trying to do, our mission is to transform the healthcare system through leadership, research, and education, rather than talk about just our members. And we have been working for 20 years on a special Hispanic health professional scholarship program with the Hispanic nurses, dentists, pharmacists, PAs, public health leaders, social workers, dietitians, and others. So we see ourselves as becoming an umbrella group for health professionals in America that are Latino to be able to galvanize their advocacy. None of them have ever been in Washington, D.C., sad to say. So for 30 years, we've been working with other groups, Hispanic, Black, Asian, women's groups, as a lone wolf in a sense. So we want to be able to add to our value of Hispanic advocates and leaders in this country that are health professionals. And the only way we're going to do that is by pulling the leaders together. So that's our advocacy role, I think. The important about women's health, though, I think for us is, again, what Linda's saying is that it really is about the stories. The mainstream doesn't understand the US-Mexico border health lifestyle. People walk back and forth all the time. People go to school on the United States side and live on the Mexican side, or people, and especially women come and shop on the El Paso and walk across the border and go back to Juarez or Laredo and the Rio Grande Valley. And there's just a mix mash of all cultural values and that's why we keep these values in the Mexican American community, especially. I'm from California, but live in DC. But on the immigrant side on the East Coast, and I have to say, and I'm just going to say this because I think it's important for people to realize, this election had a lot of mainstream networks, NBC, ABC, CB, they all did, started interviewing the immigrants on the East Coast. The immigrants on the East Coast are from Latin American socialist countries.
Yes.
And I was horrified to see some of them say, I don't believe in Democrats and Democratic leaders who want to help the poor in this country. And they think that that's socialism. Those are Hispanic people in this country right now who I don't think understand that they are part of a minority in this country that need help, because we are discriminated and we are, we have a different context in this country. And we need to help our own sisters and brothers. We're not a monolithic people. None of us are, but we have to help those that need to understand the difference between a handout, which is what our proud, humble community doesn't want, and having access to quality lifestyles. And that's what screening is all about. Why don't people get screened? Because they don't think that they need to. It's only because they don't understand what healthcare is or diseases. And most of our community is not even insured. So, 10 million Hispanics are still not insured, despite the Affordable Care Act. And I think that's 1 out of 6 Hispanics in this country, out of the 60 million. And we don't realize the impact of our own restrictions on our own community. And I'll just, my favorite topic, of course, is the health professions and having more of a workforce. And I can tell you the Latina OBGYNs that we've been training in our leadership fellowship programs, they all want to be leaders now because they see the importance that we need women's health leaders, family practice leaders, nurse practitioner leaders, but especially the OBGYNs who are being targeted by horrific policies that are not only stopping doctors from practicing and moving away from cities where are needed and rural communities, but whole hospitals are being closed down because maternity wards don't have the doctors. And it's and not only that, mental health, the burnout of our providers. So there's a lot of impact and advocacy that we need to continue. And we definitely need to work together, women's advocates across the board, and adolescents, and especially for young people to understand that they should have access to quality reproductive health and have families and continue to enjoy life like our mothers and grandmothers did.
Thank you so much for that. Any additional comments from the panelists before I go to the next question?
I've got so many, Beth. I mean, everything I've just heard is
Okay.
leaning into the discomfort, because we're just very uncomfortable right now, many of us. And the advocacy or the collaboration needed. What I've been saying is like collaboration saves lives, and here's the opportunity. So I'm co-founder of MedTech Color, and our organization, very similar to yours, Eleanor, is focused on diversifying the MedTech industry, where a lot of these technologies are developed. But when we don't have leadership that's representative of the patients and the communities we're developing these products for, they're not going to work, or we're not going to focus on those areas. Talked about maternal health, Black and brown women dying 3 to 4 times the rate of white women, just purely on our skin color, regardless of socioeconomic status, right? And then you talk about heart disease, #1 killer of women, Black women, right? So to your point, Eleanor, we need, and to everyone's point here, we need representation at all stages. I mean,
Absolutely.
healthcare delivery, you talked about it. The bias, Linda, you mentioned, it's because we don't have people that look like the patients we're trying to treat and improve outcomes for, serving them, the competent and culturally competent, culturally sensitive care, right? Care delivery. I also heard a lot about how words matter, and how you say them and who's saying them matters. I was on a panel recently with Mia Keys, who I know many of you know, and she talks about building trustworthiness back, having organizations that are trustworthy, right? Because when you're trying to engage with these communities and bring them into the fold of how we deliver care, how we access care, how we develop products, because I'm in the MedTech space, even the promise of digital health, bringing that patient voice throughout the total product life cycle, so that we're delivering and developing these products that are meaningful to them, that they're actually going to use, and that we're going to see the improved health outcomes. So I'll stop, Beth, because I know you have questions, but I'm like so excited to be on this panel with all of you working in basically, this is health equity, working to
Absolutely.
I'm
going to stay with you, Netta, for a second.
Sure.
Because to the leadership point, there's a really exciting change in leadership, right, at CDRH. So can you tell us about that?
Yes, absolutely. So I spent over 12.5 years at FDA in the Center for Devices and Radiological Health. We hear a lot about pharma or biologics, but devices affect and impact us. A lot of the software is a medical device, the digital health technologies, those are under the oversight of CDRH. And extremely exciting, actually. I think it's the first in history that we have an African-American female leader, center director, Dr. Michelle Tarver, leading that agency. And she centers around patients. She worked and brought forth the patient voice initiative, the inclusivity of patient throughout the total product lifecycle, patient preferences. I know that as regulators, and sometimes I still put my regulatory hat on and think I'm at FDA, we tend to be risk averse, but patients have the right to choose what trade-offs they want to make when deciding what products or devices can be used on them. And Michelle worked very heavily in that space. Dr. Tarver, give the doctor the pros it deserves. And then she's also worked on health equity. So health equity is now a strategic priority for the Center for Devices and Radiological Health. And it's in their next 3 years of strategy. And she worked on the breakthrough guidance document that says if you have a technology or product that can either allow better access to healthcare, especially for underrepresented, historically marginalized groups, or a technology that is addressing a disease or condition that disproportionately impacts underserved groups, FDA will consider expediting and working with the company to bring that product to market. Not to reduce, the standards to make sure it's safe and effective, but how can we actually help translate that idea from a benchtop and get it through to reaching patients, because that's our goal, right? So she's worked on a number of really impactful initiatives, including, I'll just mention my last point, the Diversity Action Plan that runs across all agencies, all centers, biologics, pharmaceuticals, drugs, as well as devices. And where now, if you're a sponsor developing some new therapy or technology or product, you need to tell the agency upfront how you plan to incorporate and enroll representative patient populations. And if you're not planning to, why not? So is it a disease that doesn't impact a certain race or ethnic group? Fair enough. But if it does, you need to be thinking proactively, establishing procedures and logistics to make sure you're going to actually enroll those patients so that our products work for the communities that need them the most.
Fantastic, Netta. So it's
Can
it's
I-
all about patients, right? At the end of the day. Mitzi, was that you?
Yes, thank you. And what, Netta, thank you for that, because that's really interesting information I didn't really know before. You know, part of the challenge for getting these innovations to market, especially medical devices and therapeutics, is the regulatory process. And it can be a real barrier if the individuals that are evaluating are not knowledgeable about that space. And so I've seen so many innovators and entrepreneurs kind of get stymied by that because they had to go back twice because they didn't have that expertise, and it cost them time and money. So one of the things that I hope that will be addressed is maybe more clarity in terms of those FDA approval pathways, but also getting the right people in the approval space.
I agree, Mitzi. I think FDA, again, CDRH, I'll speak to CDRH, my bias is MedTech, are proactive there. So when I was back at the agency, we worked on a program called Network of Experts because we recognized we didn't have all the expertise in-house. So that if we needed scientific or technical expertise, again, nothing related to policy because that's FDA's purview, that we could access them. And it's going to professional societies such as probably Elena's professional society or the orthopedic or the cardiovascular and say, we have this clinical question. So can we get some expertise to help us address this area? Another piece is also, if it is truly novel and different, FDA has a panel of experts so they can have a public meeting where they present to their experts, both FDA's perspective, having reviewed the documentation, as well as the sponsor or the company, right? And then they come out with the recommendation. And again, I'll just tout CDRH. They're the first center to have a patient panel. So now they go to patient advocacy groups to help them address critical questions. Because again, we won't have all the expertise in the center. So I totally agree with you. And I think I'm going to be the positive one. I am seeing this approach of being very inclusive, centering around patients, but recognizing where they have gaps and how they can fill that strategically, considering it's a bureaucratic agency. And at the heart of it, they're gatekeepers. They have to make sure products are safe and effective, but their mission at CDRH, and this was Jeff Shuren's, was that we're going to have products of the highest quality and the highest need reaching patients. I'm butchering his vision statement, but I'll pull it up and say it right at the end. But it's really about getting products to the patients who need them.
And Netta, I too want to be optimistic. However, the thing we know is effective technologies and therapeutics are always disparities producing because of the profit motive behind them. So the people who need them most or can't afford them don't get them. And the FDA mandate is great it has no teeth. It doesn't have to be enforced yet. So we're going to talk about advocacy. Then let's talk about building equity into product development. Let's talk about enforcing the FDA mandate so that clinical trials and MedTech recruitment and retention. It's one thing to recruit people, it's another thing to keep them in your trials, is mandated and monitored until people are held to account. Because right now, you know, if I'm a founder and I have a great idea, it's actually not to my advantage to try to make my trials inclusive, because that takes time, it costs money. I'm trying to get this thing over the finish line with the FDA. And if I'm not being held to account, I can get it over the finish line, but it's not going to be inclusive. And I'm also not going to make the money that I think that I want to make if I have to make it inclusive. So we've got to actually incentivize these developers and founders for their technology, for their therapeutics, to actually encourage them and frankly to see the value of making their trials inclusive.
By the way, it's a myth. If you think it's going to cost more and take more time, there's data on the other hand where it doesn't.
Sure.
And the carrot, the positive is you have that advantage now. You have that market advantage where you've studied the product in the patients that need it and have the data to support it. So now everyone coming behind you has to do the same thing. So
If you can get the VC folks to get on board with that.
those are like,
Okay, so speaking of, that was the next question in the 2 minutes that we have, and I'm going to have Mitzi talk about this around investment in women's health. So tell us what we can expect coming in the next couple of years.
Well, mine's more of a wish list, I think, with respect to this, because I really don't know. I'm hoping that we know that there's increased investment. We have more venture capital, firms that are focusing on women's health, more firms that are wanting to include women's health in their portfolio. And so for any of the SMEs in this area, maybe you can connect and help them evaluate. But we obviously need the research and development, because without that, we don't have the support, because we don't have the innovations. I think that tax incentives and grants for women's health investment would be really useful to start nudging some of those that have been slow to put their toe in the water. We talked about the FDA pathways, but regulatory clarity is so important, because in spite of all the good work that is being done, there's still barriers that, again, especially in the women's health space, that cost time and money, and investors lose interest or lose enthusiasm. Insurance coverage is important, because I think, again, if it doesn't get reimbursed, there's not a business model in some ways. So to encourage that. And then healthcare system integration. And this is something that I've learned from Linda, and that is, and especially as a former health insurance executive, if you don't have quality metrics that focus on women's health, then there's not the incentive. And that's something called HEDIS, which the health plans are kind of graded on, and CMS uses that. And so I think that would also bring up women's health products and services that help to meet those standards, as well as reduce healthcare costs and improve health. I mean, what I've been very, not pleasantly surprised, but very happy about is most of the innovators are doing the work to show not only outcomes, but the return on investment. And that, I think, at the end of the day, is going to move the needle.
Any other comments from the panelists on that one?
Let me just say on investment again, I think that we really need to put a positive spin on the importance of the companies, and I'm talking about the drug manufacturers themselves, opening up to more leadership positions from our communities, women's health leaders, also internships and fellowships. And I'm not talking any specific level, but there's got to be more transparency of the important role that the companies do within their marketing or within their development and innovation, and so that more people understand the importance of all of the stakeholders in our country with healthcare, but that we also are able to get to the table within these companies. And I have very limited interaction, because it's mostly government, advocacy type people that I work with are DEI, multicultural. And I'll just say that there's been a tremendous impact, I think, with the HBCU model being very, very prominent in minority health through the years, and especially with the COVID pandemic, knowing how bad our communities, all of our communities were impacted, especially rural and women and minority, just, all across the board that had to face the COVID, because they had to keep working, the essential workers. But the HBCU model is something that we really need more of, especially in the Hispanic community. And I'm going to say this because I think there's so many Latinos in this country that could get into medicine and healthcare. We don't have enough people to mentor them. So we need everybody to understand the importance of centers of excellence for certain groups who can be supported. I went to Stanford University as an undergrad, 18 years old, left home from Los Angeles, never even saw UCLA. I went to UCLA maybe once. And here I went to this fantastic university and met Hispanic and Black and Asians and whites from all over the world and the country, and had no concept of what was out there. And our communities won't know to thrive in this country and to help women's health as leaders. We need to be part of the mainstream, and the more programs we could create. And I say the HBCU model because I mean the academic world coming together with the private sector, but leading efforts to help the community that they represent.
Mm-hmm.
And that's what we need in all of so for women, we need women's centers of excellence. We've had them from NIH, but we need them to be more representative and inclusive with all of our communities. And maybe, the HBCUs, the Hispanic, the tribal, Asian, whatever, and come together to have more research and mentoring for the next generation.
Thanks for that. And on the research issue, Linda, I think you had specifically talked about, and one of the questions I was going to ask you was around, concerns, right, about women's health research and how much funding there's going to be. And what I've seen we're sort of moving into Q&A as well, but I want to hear your comments. But in the Q&A, there are several questions around, what can we expect in terms of funding, right, from the NIH, there's the ARPA-H funding and all of that. So what your thoughts there?
Yeah, it will be interesting to see. I'm on board with everyone else. The White House initiative on women's health research was a tremendous step forward to increase funding for women's health research. We'll see what happens. This was an executive order, so I don't know. I hope folks in the new administration will continue to see the value. Spending on women's health research is, significantly less than for men. And so we've got a long way to go. And if you look at women of color, it's, even less, and we continue to be left out of research. The Black Women's Health Imperative is just started the first, and kind of the research that needed to happen around breast cancer and cervical cancer screening. So we'll finally be able to answer that question of when and how often we should start screening. We need to stop talking about it. We need to put solutions
right.
in.
Get the data.
Way. And so that will help, but whether or not anybody at the government will pay attention to it and adopt it, we'll see. That's, the U.S. Preventive Services Task Force, that quasi-government agency makes those guidelines. But I would just say, from an advocacy perspective, since that's what we're talking about, we've got to make the business case for research in women's health. We've got to make that business, and it is easily made, as you've heard, but we've got to look at the economy, national, the local economy, corporate performance, the impact on state and local taxes, employment, and frankly, national security. 70% of incoming freshmen to colleges can't pass the basic physical exam test required for military service. So even if they're not planning to do that, they're on a trajectory that is not healthy. And so we have a lot to do, and we need to show businesses, policymakers, what's at risk to not only kind of our health, but their bottom line. And, as Ellen has said, the workforce, it's a huge issue.
Mm-hmm.
Absolutely. And in the Q&A, there was a specific question around cuts to women's health research funding at the NIH, ARPA-H, et cetera. if I have it right, and Liz, you can correct me, there is, in your comments, there is appears to be bipartisan support for policies to advance the health of women. So there are appropriations bills, I believe, to increase at least funding from the NIH in the Office of Women's Health. So I'm optimistic, but as Linda just said, we will see, right? But it's desperately needed. And so that's, for me, also where the advocacy comes in, right, in terms of pushing and pushing and pushing for research in women's health, especially considering all that we don't know, right? Sex differences, et cetera, cardiovascular disease, Alzheimer's, all of those things that we talk about. So extremely important. Let's see. I'm going to see if there are any comments as I'm looking for from our panelists as I'm looking for an additional question. And then
There was a question about the ARPA-H funding, the Sprint
yes,
Health. That money's being issued. If you got the money, get that money. I think
yes,
there's potentially more money in there available. There's a lot about like you said, the business case. Well, the business case has been made. Women are what, over 80-something% consumers of healthcare, and they're the chief medical officer for all their families, chief medical decision makers, whatever chief, they're just the chief women, right? So if you're not engaging them or marketing to them or thinking about them, you've lost out. So, I mean, the business case is there, the WAM report, there's just so much data out there that shows you're way behind the curve if you're not thinking about who's actually consuming healthcare.
I think the challenge, all of that being absolutely true, Netta, is at the end of the day, we need investors, right, to invest. And many of them are not necessarily interested in, say, the economy, right? What's great for the economy? They want to know, what's my return? What do I get out of investing, right? And that's where I think there's still a little bit of a gap, and where we need to make, we need successes. We need to see, companies being, successful, et cetera, et cetera. And that's where the research comes in as well, right? So it's.
But can I challenge you? It's because the incentives are misaligned. So first of all, we could just say the investors don't look like, say,
True.
the innovations and the innovators and those women who are trying to create change or create products in this space, right? It goes back to Eleanor, where the leadership isn't
Yes,
someone
right.
that understands. So we know the plight of some, if you're a female founder or founder of color, to try and raise money in the space is just that uphill climb.
Absolutely.
But then the return, they want to return now. You can't have a return now. It's like a long term, it's the journey. It's not the destination. And that's where I think there needs to be a whole shift of looking at how we invest and how, what the incentives are. I'd love to hear other people's thoughts on here, because they're just misaligned.
Yeah, Netta, it's hard to balance impact and your exit strategy, because you're trying to get out quickly to take your $100 million with you. And it's, to your point, there's an inherent conflict. So until we, and I don't in any way mean to sound sort of Pollyanna-ish, but we do have to value women. And so that's a whole other discussion, perhaps, Beth. But while you're right, we can make the business case, we do have to make the value case. And
That's
I think we can. I think we can.
That's right. I agree with you 100%.
Yeah.
All right. We are at, go ahead.
No, it's okay. I feel like I should say something, but a couple of things.
Liz
Number
will
one
grab us off in a minute, but go ahead.
No, that's okay. I think that, and again, I'll echo Linda, not to be Pollyanna, but I do think that, again, the successful entrepreneurs are ones that, number one, look at the exit from the beginning and start making those strategic collaborations and partnerships. But also, again, if they can, and again, I know that there's bias and some people still think this is a niche market, but I do hope and think that as you see those companies reducing healthcare costs, improving outcomes for the payers, and for those that are making the decisions, and then they become more valued, then they become valuable companies. And so I would, for anybody that's an entrepreneur in there, to just, again, keep that in mind. Again, it doesn't always work out that way, but I think we're going to see much more traction as we go along. And if I can make one really quick comment, what we haven't talked about is the impact of state and local governments and opportunities there. And I would say that to Elena's point about women's health centers, and we've talked about our women's centers of excellence, and I know there's been a lot of talk about that to include innovation. The center that I was the founding medical director of was one of those early ones that focused on research, education, delivery. I feel strongly, and I think that there's agreement, we need to add innovation. And so if you can do that and come together in a community, for example, we're looking at this in Arizona about being a hub for women's health innovation and bringing in all the players such as scientists, investors, government, and all of that, and payers. We might be able to move the needle in our own communities, and that might be a little bit more accessible. So I'll leave with that hopeful comment.
Yep, it's all about bringing together the full ecosystem, right? All right,
Exactly.
with that, I'm going to turn it back to Liz, who now has 2 minutes to finish up. But this was a great discussion. Thank you so much to all the panelists.
Thank you so much. I'm going to put up some slides again. So just wanted to close out with what to expect next. So in Congress, we're going to have new chairs in the Senate of some key committees that have oversight over health. So you've got the Energy and Commerce Committee, which has the Health Subcommittee, the Senate Health Committee, Health, Education, Labor, Pensions Committee, the Senate Finance Committee, and then the Appropriations Committee. They have all these different subcommittees. And so Susan Collins will now become chair of appropriations. Shelley Moore Capito will become chair of the health funding subcommittee. So it's great. We'll have women in power in the Senate who really care about women's health issues. They join together to do the menopause legislation. There's actually a congressional briefing happening right now on that exact topic. And Murkowski is another big champion of that. So we are actually in a really good position for new Senate leaders. We had great ones before in Murray and Baldwin, but I think that they work very well together in a very bipartisan way, and they're very passionate about women's health. There's also this geographic shift that's happening as chairs shift. So you can see moving from the state of Washington to the state of Maine, that's a big shift. Wisconsin to West Virginia, Montana, Kentucky, Vermont to Louisiana, et cetera. So what that just means is when the new chair comes in, they get to control so much. And so, their lens is what's going to determine the parameters of legislation. So it is important to think about geography. The other thing is rules. So any new rule that went into effect around August 1st or later can be overturned. So there are folks that are looking through everything to determine what they're going to nix. So that is something that we have to watch for. Women in office keeps growing. For the first time ever, we're going to have 2 Black women serving in the Senate simultaneously. And then medical professionals. We actually have 6 new clinicians elected to office. Plus there's already about a little over a dozen that's already there. So that's always good when you're talking about health issues. So for the White House, there will be a sprint the first 100 days. They're consumed with their appointees. We are hearing announcements about various appointees that Trump is determining now. We'll hear lots more. There'll be a big focus on the government efficiency department that he's creating, that Musk and Ramaswamy are going to run. Which is, as someone who lives in the DMV area, is a little scary. I think that a lot of folks are worried about their jobs. So we'll see what happens with that. Department of Health and Human Services is obviously a big focus. FDA, who's going to run that? What's the role of RFK Jr., especially with his past stance and active stance on vaccines? There's a lot of concern there. A lot of people think he is not someone who could get through the process with the Senate to get approved. So he will likely play some advisory role. And then reconciliation will be a big focus. I'm going to talk about that in a second. And then I think those are the main things from the White House. Now, what is going to stay and what is going to leave? So we heard the question on ARPA-H. Those awards were made, so those are not going to be taken away. So that's good. What's interesting though is right now in the House version of the appropriations bill, they need to finish up for the current fiscal year. It slashes ARPA-H to 500 million and the Senate version has 1.5 billion. So there will be a fight. They might just really starve that program. We'll have to see what happens in future appropriation cycles. But if you got an award, you have your award. Access to biological variable was announced as part of the DoD grant process in July. So that is safe. 500 million is the annual spend on grants that are funding women's health research. I think that will stay relatively in that ballpark because it was already happening. The Office of Research on Women's Health, Beth touched on that. It's got increased funding in both the Republican-controlled House and the Democratic-controlled Senate. So that's great. There is support across the board for that office. Interestingly, it's a bigger increase in the Senate. It's 100 million in the House and 152 million in the Senate. But an interesting difference also is with NCI, National Cancer Institute. The House bill actually has more funding at 7.9 billion. And the Senate has 7.5 billion. So the Republican-led House feels very strongly about cancer research. So there are definitely some interesting things that will stay or could grow. Affordable Care Act, we don't think that's going away, but it will probably get an overhaul. There'll be lots of changes. Interestingly, they just elected today John Thune from South Dakota to be the Senate Majority Leader to replace Mitch McConnell. He is a longtime member of the Senate Finance Committee, which does all CMS. So that's all Medicare, Medicaid oversight. So he knows those issues well. He's pretty passionate on rural health and access issues. So that reimbursement issue around surgeries, that is totally discriminatory, how it is reimbursed right now for urogynecological surgeries as compared to male urology surgeries. That is something that we might actually get some legs on. So it's great that someone has that sort of health background, Senate Finance Committee background, leading the Senate. So what's gone? Expansion of the over-the-counter contraception access. That was a new rule that the White House just came out with before election. The White House Initiative on Women's Health Research, Gender Policy Office, ARPA-H. We're not sure. As we said, it might get just kind of starved or merged. So the latest proposal by the current chair of the Energy and Commerce Committee, Kathy McMorris Rodgers, was to do this consolidation effort and to really decrease significantly the number of institutes and centers at NIH from 27 to 15. So that could have huge ramifications and would decrease funding. However, it was a proposal. Little part of it was included in the House version of the appropriations bill, definitely not included in the Senate version. We are hearing that now they're going to punt and complete the appropriations process probably by March next year, which means it's a completely Republican-controlled government that will then make these decisions. So that is definitely at risk. Some consolidation effort at NIH is probably still at risk. So that is something that we would want to advocate on. The global gag rule ban will be gone. This flips every time it's a switch from a Republican to a Democratic president. It is stricter under Trump. He actually enforced a stricter ban, including all sources of funding for NGOs. So that will definitely have an impact. I think some positive things that are gone. TSET, I don't think has been particularly helpful for breakthrough devices. Trump in his previous administration was more aggressive on bringing new innovations to market faster by getting coverage quicker. So once you had FDA approval, you could get faster coverage from CMS. I think that's going to change. The SBIR innovation tax also has been very detrimental to folks getting SBIR awards. They had to then give over a percentage of that in taxes, which is crazy. There's been a whole effort. We've been working to change that, and it did pass the House under Chairman Jason Smith. And we expect with an all-Republican Congress that could definitely be fixed as well. So advocacy opportunities. There's so many opportunities coming up. Tax cuts, the tax package, the Job and Tax Cut Act that Trump championed in his first administration when they had all Republican control, though many of those provisions are going to expire. So there are opportunities in there. There's the child tax credit, for example. There's opportunity zones tax program. There could be ways to carve out around women's health investment. I think that there's lots of interesting opportunities. R&D tax, R&E tax, maybe there's ways to carve out for women's health innovation given the huge disparity in VC backing. So I think there's opportunities there. Reconciliation process. So that's a two-step process that you can do with a simple majority. And we are definitely expecting that very quickly. Could be done in the first 100 days. Usually the budget resolution has to be done by April 15th. And then the legislation that actually enacts all the funding changes by June 15th. But we have seen them mess with that deadline. The House has a rule that they won't go into recess unless they get that reconciliation done by that recess timeframe. But we'll see what happens with that. I definitely think there'll be reconciliation though. That is how they're gonna push through all kinds of changes in funding and in taxes. There's the appropriations process. So they'll finish up in March-ish, the current one, and then they'll get started on the next one. And so I think there's lots of opportunities to include language and funding directives in the appropriations bills. We have seen huge changes just in the past couple years in those appropriation bills supporting women's health. I won't get into all the details, but there's lots of references. There's lots of support and interest that's across the aisle. There's regulatory influence, there's letters and testimony, events and social media that has driven a lot of change actually in the policy arena. So advocacy. So we have the Women's Health Advocates Program. We've created all these organizations, Women's Health Innovation Coalition, Coalition for the Health of Women, Women's Digital Health Network, the Breast Cancer Early Detection Coalition, and many more. These are all solely focused on lobbying and advocacy in women's health. We are going big, creating a steering committee to really advance this effort in 2025. We want to plan events to educate on women's health in a bipartisan way and build lots of support. We think it's very possible. We already saw lots of support from Democrats and Republicans in Congress long before this election. We're going to work on a Capitol Hill Day focused on women's health next spring. Lots of sign-on letters. Remember that sign-on letter that many of you joined me on? We had over 1,000 signatures that we sent to the House and Senate appropriators that actually influenced the process. The Office of Research on Women's Health got that big boost, I think in part because of our letter, because of all of you, because of many women's health organizations advocating for that. So stay informed, stay engaged, and definitely take action. And that is our presentation for today. Thank you so much again for dialing in. We hope that you will join us and become a women's health advocate. Thank you so much.